Your doctor has been checking your blood work for years. Cholesterol, acceptable. Blood sugar, within range. Blood pressure, fine. And yet something is wrong. Your energy is not what it was. Your waist keeps growing regardless of what you eat. Your mind feels slower, foggier. You go back to your doctor, and he says the same thing. Your numbers look okay. Keep doing what you're doing. What if the numbers your doctor checks are not the ones that matter most? What if there is an organ sitting in your body right now, executing over 500 metabolic functions every single day, that your doctor has never once seriously evaluated? An organ that, when it starts to fail silently, sends a cascade of damage through every other system in your body. An organ that the research identifies as the common root of most chronic diseases that kill people between the ages of 45 and 65. Before I continue, I need to be clear with you. Everything I share today is educational information grounded in peer-reviewed science. It is not a substitute for medical care. If you have a diagnosed liver condition, are managing diabetes, cardiovascular disease, or any chronic illness under medical supervision, please work with your doctor before making changes based on what you hear here. This information should be in your doctor's office. In too many cases, it simply isn't. I'm Dr. Harris. I've been practicing clinical medicine for over 15 years. What I share on this channel comes from the research itself, not from the consensus guidelines that pharmaceutical companies fund, not from the panels where the same names rotate every 5 years, from the actual studies, the mechanisms, the data your 10-minute appointment was never designed to communicate. Today I'm going to show you exactly what this organ does, why its silent dysfunction is driving most of the chronic disease epidemic we are living through, and what one specific food, backed by the largest nutrition trial ever conducted, does to begin reversing that damage. If you have been searching for why you feel the way you feel despite doing everything right, this video is the one you have been looking for. Subscribe if that's what brought you here. I publish this so that the information is accessible outside the walls of a medical consultation. Now let me start with the thing the system has gotten exactly backward. For decades, the standard approach to chronic disease has treated each condition as its own isolated problem with its own isolated solution. High cholesterol gets a statin. High blood sugar gets metformin. High blood pressure gets an ACE inhibitor. Fatigue gets a referral to a psychiatrist. Brain fog gets told it's just aging. You end up managing 4 separate diagnoses with 4 separate specialists who never speak to each other, while the underlying mechanism that connects all of them goes completely unaddressed. That mechanism lives in the liver. The liver is the only organ without which no other organ system can function correctly. Not the heart, not the brain, not the pancreas, not your immune system. Every one of them depends on what the liver does. It executes over 500 documented metabolic functions. It produces the proteins that control how your blood clots. It synthesizes the cholesterol your cells need to function. It regulates glucose output, meaning it controls how much sugar floods your bloodstream between meals. It metabolizes every hormone your body produces, including estrogen, testosterone, and cortisol. It filters everything that enters your bloodstream from your gut before it reaches the rest of your body. And critically, when it is under stress, it produces inflammatory proteins that circulate throughout your entire system. Here's the part the system never tells you. When the liver is inflamed, even mildly, even subclinically, meaning below the threshold your standard blood panel would flag, it begins producing a class of proteins called acute phase reactants, C-reactive protein, fibrinogen, interleukin-6. These are the same inflammatory markers that show up elevated in cardiovascular disease, in type 2 diabetes, in metabolic syndrome, in early cognitive decline. Your cardiologist sees the CRP and treats the heart. Your endocrinologist sees the insulin resistance and treats the pancreas. Your neurologist sees the cognitive symptoms and prescribes something for the brain, but no one is asking where the inflammation is coming from in the first place. This is not a theory. A study published in the Journal of Clinical Investigation by Schulson and colleagues demonstrated something that should have reorganized how we approach metabolic disease. Using both animal models and human clinical validation, they showed that activation of the inflammatory pathway IKK-beta and NF-kB specifically within liver tissue is sufficient, on its own, to induce systemic insulin resistance and the full picture of metabolic syndrome throughout the body. One organ inflamed, and the downstream result is a cascade of metabolic dysfunction across every major system. The system treats each downstream consequence as a separate disease. The evidence says they may share a single upstream source. Now here is where the data gets more disturbing. Non-alcoholic fatty liver disease, NAFLD, is the clinical term for early liver dysfunction. It means fat has begun accumulating in liver tissue in someone who does not drink excessively. The standard criteria for being diagnosed with NAFLD requires a specific threshold of fat infiltration visible on imaging. But here is what the standard criteria misses. Metabolic liver dysfunction begins well before you reach diagnostic threshold. The inflammatory signaling, the disrupted glucose regulation, the altered lipid metabolism, these are happening at earlier stages that routine blood panels do not catch, and that your doctor is not looking for unless you present with jaundice or severe enzyme elevation. How common is subclinical liver dysfunction in the age group watching this video? A 2019 prospective cohort study published in Hepatology by Weinstein and colleagues followed 2,735 adults from the general population, not patients already diagnosed with liver disease, but a general community sample. What they found: adults with NAFLD had a 34% higher risk of cognitive decline compared to adults without NAFLD, even after controlling for age, cardiovascular risk factors, diabetes, and other confounders. 34%. And most of those people with NAFLD had no idea they had it because their standard checkups were not designed to find it. Here's the question your doctor has probably never asked you. When you mentioned brain fog at your last appointment, did anyone check your liver enzymes? Did anyone ask about your liver at all? The answer in most cases is no. And this is not because your doctor is incompetent. It is because the system has organized medicine into specialties and subspecialties that rarely communicate, with guidelines written by committees that have significant representation from industries that profit from treating downstream consequences rather than upstream causes. The pharmaceutical management of high cholesterol, type 2 diabetes, and hypertension generates hundreds of billions of dollars annually. Addressing the liver dysfunction that may underlie all three does not generate that kind of revenue. There is no liver health drug with a television advertising budget. Let me take you through the evidence because this is where the conversation gets serious. The study that changed my clinical perspective on this topic was the PREDIMED trial. PREDIMED stands for Prevención con Dieta Mediterránea. It was a randomized controlled trial, the most rigorous study design in medicine, conducted across multiple Spanish clinical centers by Estrich and colleagues. It enrolled 7,447 adults between the ages of 55 and 80 who were at high cardiovascular risk but had not yet had a heart attack or stroke. The study ran for a median of 4.8 years. It was published in the New England Journal of Medicine in 2013, was later reanalyzed in 2018, and its primary conclusions held. Here's what they found. Participants randomized to a Mediterranean diet supplemented with extra virgin olive oil, approximately 1 liter of olive oil per week, experienced a 31% reduction in major cardiovascular events compared to the control group. 31%. They also found a 40% reduction in new-onset type 2 diabetes in the olive oil group, and significant reduction in cognitive decline, not from a drug, from a dietary fat, from 1 liter of extra virgin olive oil per week. No cardiovascular drug on the market has that benefit-to-risk profile for cardiovascular outcomes. Statins, the most widely prescribed cardiovascular medication in the world, reduce cardiovascular events by approximately 25 to 35% in high-risk populations, but they come with documented risks of muscle damage, elevated liver enzyme levels, and increased risk of type 2 diabetes. Extra virgin olive oil produced comparable cardiovascular risk reduction with no documented adverse effects in the PREDIMED population. Your doctor knows about PREDIMED. It was published in the New England Journal of Medicine and covered extensively in mainstream medical media. But when was the last time a doctor prescribed you a liter of olive oil per week? The PREDIMED study captures the systemic effect. But to understand why extra virgin olive oil produces these results, you need to understand what it does specifically in the liver. A randomized controlled trial by Hernandez and colleagues published in the British Journal of Nutrition in 2017 addressed this directly. They enrolled 51 adults with confirmed NAFLD, non-alcoholic fatty liver disease, and randomized them to either continue their usual diet or substitute saturated fats with extra virgin olive oil for 6 weeks. 6 weeks. The results in the olive oil group: a 15.3% reduction in hepatic fat content, an 18% reduction in ALT, which is the liver enzyme that indicates liver cell stress and inflammation, and a 21% reduction in HOMA-IR, which is the standard clinical measure of insulin resistance, in 6 weeks, with a dietary fat substitution. The limitation here is the short duration and small sample size. What this study cannot tell us is whether those changes persist and compound over months and years. What the PREDIMED data suggests, with nearly 5 years of follow-up in thousands of patients, is that they do. Now, the second food in this evidence base comes from a completely different mechanism, and it is one that the pharmaceutical industry spent years and enormous resources trying to replicate with drugs, without success. A double-blind, randomized controlled trial by Bahadurin and colleagues published in Diabetes and Metabolic Syndrome, Clinical Research and Reviews in 2012, enrolled 72 patients with both type 2 diabetes and NAFLD, a common combination, for reasons I'll explain in a moment. They randomized participants to broccoli sprout extract standardized to sulforaphane content, equivalent to approximately 5 grams of broccoli sprouts per day of active compound. Duration, 4 weeks. The results: a 23% reduction in ALT, a 19% reduction in AST, which is the second liver enzyme your doctor measures, and significant reduction in markers of oxidative stress. 4 weeks, 72 patients. Double-blind design. The limitation is important. This was broccoli sprout extract, not whole broccoli. Sulforaphane content in whole broccoli varies enormously depending on how it is prepared, and I'll tell you exactly how to maximize it in a moment. But the mechanism here is among the most compelling in the nutritional science literature, and here is why. Now let me take you through the biology, because this is where the systems approach falls apart. The first mechanism is what the research calls hepatic origin systemic inflammation. In plain language, when your liver is stressed, it becomes a factory for inflammatory signals that travel throughout your entire body. The liver contains specialized immune cells called Kupffer cells. Under normal conditions, Kupffer cells clean the blood that arrives from the gut, filtering out bacterial products, food antigens, and metabolic waste before they reach the rest of your body. When the liver becomes inflamed from excess dietary fat, from alcohol, from processed food metabolites, from gut bacteria imbalance, Kupffer cells become chronically activated. They begin producing TNF-alpha, IL-6, and IL-1 beta. These inflammatory cytokines don't stay in the liver. They enter the bloodstream and reach every organ. Think of the liver as a municipal water treatment plant. When the plant is functioning correctly, it filters out contaminants before clean water reaches the city. When the treatment plant breaks down, every tap in the city starts delivering contaminated water. Your doctor is treating symptoms at individual faucets, adding filters here, replacing pipes there, while the treatment plant continues to malfunction. The evidence says you need to address the plant. This mechanism directly explains the Schulson findings I referenced earlier. When NF-κB inflammatory signaling is activated specifically within liver tissue, it produces systemic insulin resistance. This is not a local liver problem. It is the liver generating a metabolic disruption that affects how every cell in your body responds to insulin. Your pancreas works harder, blood sugar climbs, your doctor responds by prescribing metformin, but the liver, which started the chain, is not being addressed. The second mechanism is what researchers call NRF2 pathway regulation, and this is where extra virgin olive oil and sulforaphane from broccoli do something no pharmaceutical drug has successfully replicated at scale. NRF2, nuclear factor erythroid 2-related factor 2, is a transcription factor. It is essentially a master switch that, when activated, turns on over 200 genes involved in antioxidant defense and detoxification. When NRF2 is active, your liver cells can neutralize reactive oxygen species, metabolize toxic compounds, and resist cellular damage from inflammatory signals. Here is the aging component. Research has established that NRF2 activity declines significantly with age. By age 60, NRF2 pathway activity is estimated to be roughly 50% of what it was at age 30. This is not a disease process, it is a normal aging trajectory. But the practical consequence is that the liver's capacity to defend itself against inflammatory and oxidative stress drops by half over your adult lifetime, precisely in the decades when metabolic stress on the liver is typically increasing. Think of NRF2 as the rust prevention coating on a metal structure. In your 20s and 30s, the coating is thick and well maintained. By your 50s and 60s, it has thinned. Corrosion that would have been neutralized years ago now takes hold. This is not inevitable damage. The coating can be reinforced. And this is exactly what sulforaphane does. Sulforaphane is the most potent dietary activator of NRF2 identified in the research to date. When it enters liver cells, it directly induces NRF2 expression, which then activates the genes responsible for glutathione synthesis. superoxide dismutase production, and phase 2 detoxification enzyme activity. These are the liver's primary internal defense systems. The pharmaceutical industry recognized the therapeutic potential of NRF2 activation and spent years developing synthetic NRF2 activators. Clinical trials were disappointing. The drugs produced off-target effects and systemic toxicity that broccoli-derived sulforaphane at dietary doses does not produce. The oleocanthal and oleasin compounds in extra virgin olive oil activate NRF2 through a parallel pathway, and they also directly inhibit the same QX enzymes that ibuprofen inhibits, giving extra virgin olive oil a mild anti-inflammatory mechanism at the liver level that is, in terms of mechanism, pharmacologically similar to a low-dose NSAID without the gastrointestinal and renal side effects of chronic NSAID use. The third mechanism is the liver-gut-brain axis, and this is the connection that most directly explains the cognitive symptoms your doctor has probably never linked to liver function. The liver receives approximately 70% of its blood supply from the portal vein, the blood vessel that drains the entire intestinal tract. Everything absorbed from your gut passes through the liver before reaching systemic circulation. When liver function is impaired, two things happen that affect the brain. First, the liver loses efficiency at clearing ammonia, a byproduct of protein metabolism produced continuously by gut bacteria. Normally, the liver converts ammonia into urea, which is excreted through the urine. When liver function is compromised, circulating ammonia levels rise. Ammonia crosses the blood-brain barrier. It alters neurotransmitter synthesis. It impairs astrocyte function, the brain's primary support cells. In clinical hepatic encephalopathy, the severe end of this spectrum, patients present with confusion, personality changes, and loss of consciousness. But the research, including the Weinstein cohort study I cited earlier, shows that cognitive effects occur well before reaching clinical hepatic encephalopathy. Mild elevations in circulating ammonia, subclinical, not measured in routine blood work, are associated with measurable deficits in processing speed, memory consolidation, and executive function. Second, the gut-liver-brain axis is disrupted by increased intestinal permeability, what some researchers call leaky gut, though I prefer the more precise term, altered gut barrier integrity. When the intestinal lining becomes more permeable, bacterial lipopolysaccharide, LPS, the outer membrane component of gram-negative gut bacteria, crosses into the portal bloodstream in higher concentrations. The liver is the first line of defense against circulating LPS, and a healthy liver clears it efficiently. A stressed liver does not. LPS that escapes hepatic clearance reaches the brain, where it activates microglial cells, the brain's immune cells, and drives neuroinflammation. This is a documented mechanism underlying multiple neurodegenerative conditions, including Alzheimer's disease. Think of it this way. The gut is producing a constant stream of metabolic byproducts, some beneficial, some potentially harmful. The liver is the filtration system that sits between the gut and the rest of the body, including the brain. A compromised filtration system means contaminated output downstream. Your doctor treating brain fog with an antidepressant is addressing the symptom at the destination while the contamination continues at the source. Now here's what you actually do about this, and I want to be very direct. Everything in this protocol section is designed to complement, not replace, whatever treatment you may currently be under. If you are being monitored for a liver condition, diabetes, or cardiovascular disease, take this information to your doctor and decide together what makes sense for your specific situation. The first priority with the strongest evidence base is extra virgin olive oil at a therapeutic dose. The PREDIMED protocol used 1 liter per week, which works out to roughly 4 tablespoons per day. This is significantly more than the amount most people use. The Hernandez NAFLD study used a similar quantity. The evidence for cardiovascular risk reduction, liver enzyme normalization, and insulin resistance improvement is anchored at this dose range, not at the tablespoon here, tablespoon there level most people practice. How to implement this? 4 tablespoons per day, divided however makes sense for your eating pattern. On salads, over cooked vegetables, as a dip with bread, drizzled over fish or legumes. The critical specification is extra virgin, not pure olive oil, not light olive oil, not refined olive oil, extra virgin. The oleocanthal and oleacan content that drives the anti-inflammatory and NRF2 activating effects is present only in the unrefined, cold-pressed product. These phenolic compounds are destroyed or removed in the refining process that produces lower-grade olive oils. The caloric consideration is real. 4 tablespoons of olive oil is approximately 480 calories. If you are on a calorie-restricted diet, you are not adding these calories on top of your current intake. You are substituting them for other fats. Replace butter, replace refined vegetable oils, replace the processed foods that contain those oils. This is a substitution protocol, not an addition protocol. The most common mistake, buying low-quality oil labeled extra virgin that has been adulterated with refined oils. This is widespread. Research at the University of California, Davis found that a significant percentage of olive oils sold as extra virgin in American supermarkets fail the chemical standards for genuine extra virgin quality. Look for oils with a harvest date on the label, not just a best buy date, from single origin producers, or from countries with strict certification standards like Spain, Italy, or Greece. Price is a signal. Genuine high polyphenol extra virgin olive oil is not cheap. One important safety note before moving on: if you are currently on anticoagulant medications, warfarin, apixaban, rivaroxaban, high doses of olive oil may have a mild potentiating effect on anticoagulation through vitamin K content interactions. Discuss with your prescribing physician before significantly increasing your intake. The second priority is cruciferous vegetables, specifically optimized for sulforaphane delivery. Broccoli is the most studied, but the category includes cauliflower, Brussels sprouts, kale, arugula, bok choy, cabbage, and radishes. The Bahadurin study showing 23% ALT reduction used broccoli sprout extract. Regular broccoli contains the precursor to sulforaphane, called glucoraphanin, along with an enzyme called myrosinase that converts it to active sulforaphane when the plant tissue is damaged. Here is the critical preparation detail the research establishes. Myrosinase is heat sensitive and is destroyed at temperatures above approximately 70 degrees Celsius, well below boiling. Microwaving destroys it almost completely. Prolonged boiling destroys it significantly. To maximize sulforaphane yield, cut or chop your broccoli and then wait 5 to 10 minutes before applying any heat. Chopping activates the myrosinase enzyme, which converts available glucoraphanin to sulforaphane during that window. After 10 minutes, brief steaming, 5 to 7 minutes, preserves more sulforaphane than boiling or microwaving. Eating it raw or very lightly steamed produces the highest sulforaphane content. The protocol: 1 to 2 portions of cruciferous vegetables daily. A portion is approximately 1 cup of chopped broccoli or equivalent. 1 portion daily is meaningful. 2 provides substantially more NRF2 activation. Broccoli sprouts, available at specialty grocery stores and easy to grow at home in a jar, contain roughly 10 to 100 times the glucoraphanin concentration of mature broccoli, meaning a small handful of sprouts produces the sulforaphane equivalent of a much larger quantity of mature broccoli. One caution here: cruciferous vegetables contain compounds called goitrogens, which in very large quantities can interfere with thyroid hormone synthesis by competing for iodine uptake. If you have untreated hypothyroidism, discuss this with your physician before dramatically increasing cruciferous vegetable intake. For people with normal thyroid function or hypothyroidism that is properly managed and monitored, 1 to 2 portions daily is not clinically problematic. This is a consideration, not a prohibition, but it warrants mentioning. The third priority is legumes: lentils, chickpeas, black beans, kidney beans, white beans, and the evidence base here extends across multiple meta-analyses covering NAFLD, diabetes, and cardiovascular risk. A 2014 systematic review and meta-analysis in the American Journal of Clinical Nutrition, pooling data from 41 randomized controlled trials, found that legume consumption was associated with significant reductions in fasting blood glucose, insulin levels, and LDL cholesterol compared to control diets. The mechanism involves multiple pathways: high soluble fiber content that slows glucose absorption, prebiotic fiber that feeds beneficial gut bacteria and reduces the LPS-producing bacteria that drive the liver-brain inflammatory axis I described, and a specific amino acid profile that supports hepatic detoxification enzyme function. The protocol: 1 cup of cooked legumes daily, any variety at any meal. Lentil soup at lunch, chickpeas in a salad at dinner, black beans as a side. The preparation method matters less here than consistency. If you are not accustomed to high legume intake, increase gradually over 2 to 3 weeks to allow gut microbiome adaptation and minimize gas production. This is a transit issue, not a safety issue, and it resolves with consistent intake. Now here's what you need to bring to your next medical appointment, because this is where most people make the first mistake. They start a protocol but have no way to measure whether it is working. The standard liver panel your doctor orders includes ALT and AST. These are useful, but they are lagging indicators. They elevate when liver cell damage is already occurring. For early stage assessment, ask specifically for GGT, gamma-glutamyl transferase. GGT is more sensitive than ALT for early hepatic stress and is particularly responsive to dietary fat metabolism changes. It is not included in most standard metabolic panels unless specifically requested. Optimal GGT is generally considered below 20 units per liter for men and below 15 for women, which is significantly lower than the laboratory reference range that most labs report as normal. Also ask for total and direct bilirubin, useful for assessing how well the liver is processing red blood cell breakdown products, prothrombin time or INR, which reflects the liver's synthetic function, its ability to produce clotting proteins. Ferritin and transferrin saturation together. Elevated ferritin with high transferrin saturation can indicate iron overload, which directly drives hepatic oxidative stress and is underdiagnosed, and a fasting insulin level in addition to fasting glucose. Fasting glucose can be normal, while fasting insulin is already significantly elevated, revealing early insulin resistance that the glucose number alone misses. The HOMA-IR calculation, which uses both fasting glucose and fasting insulin, is a more sensitive marker of metabolic liver stress than glucose alone. If your ALT and AST have been persistently elevated, even mildly 2 to 3 times above the upper limit of normal on repeated testing, ask your physician about FibroScan. This is an elastography technique that measures liver stiffness non-invasively, providing information about fibrosis staging that blood tests cannot reliably detect. It is widely available in hepatology practices and increasingly in general gastroenterology. After 15 years working with patients on metabolic liver health, the clinical insights that don't make it into any protocol document, but that consistently separate people who see results from those who do not. The first is that timing matters in ways most people ignore. The liver's detoxification enzyme activity follows a circadian rhythm. Phase 2 liver enzymes, the ones that neutralize most harmful compounds, are most active in the early morning hours. There is emerging evidence that eating within a compressed time window and completing caloric intake earlier in the day, essentially front-loading calories rather than eating a large meal late at night, reduces nocturnal metabolic stress on the liver. This does not require formal intermittent fasting. It means that a substantial dinner at 10 at night repeatedly imposes a different metabolic burden on your liver than the same meal eaten at 6. The second insight: the synergy between olive oil polyphenols and fat-soluble nutrients is real and documented. Eating leafy greens, carotenoid-rich vegetables, or fat-soluble vitamins with extra virgin olive oil significantly increases absorption of those nutrients compared to eating them with refined oils or no fat. This is not incidental. The fat-soluble nutrients most relevant to liver health, vitamins A, D, E, K, and the fat-soluble carotenoids like lycopene and beta-carotene are specifically absorbed through the same pathway that olive oil polyphenols travel. Eat your colored vegetables with olive oil. The third, alcohol, even at moderate levels, directly competes with every mechanism in this protocol. Alcohol is metabolized almost exclusively in the liver, and its metabolism generates reactive oxygen species that deplete glutathione, which is the primary antioxidant that NRF2 activation produces. If you are actively working on liver repair, even moderate alcohol consumption meaningfully offsets what you are trying to achieve. This is not a moral judgment, it is biochemistry. The fourth, sleep is not optional for this protocol. Growth hormone secretion, which drives hepatic regeneration, occurs primarily during slow-wave sleep. Cortisol, which elevates in sleep deprivation, directly promotes hepatic fat accumulation by stimulating gluconeogenesis and lipogenesis in liver tissue. The protocol works better with 7 to 8 hours of sleep. I have seen patients do everything right nutritionally and see minimal progress because they were chronically sleeping 5 to 6 hours. The liver repairs itself at night. You need to give it the conditions to do so. Now, the question I get consistently: how long before you see results? Based on the study timelines and the evidence I reviewed today, within the first 1 to 2 weeks of consistent implementation, most people report subjective improvements in energy and reduction in afternoon fatigue. This is not placebo. It is partly explained by the rapid effect of polyphenols on gut microbiome composition. Changes in microbiome diversity have been documented within 48 to 72 hours of dietary shifts. You are not repairing the liver in 2 weeks, but you are beginning to alter the inflammatory signaling environment. At 4 to 6 weeks, if you have your GGT and ALT checked, the Hernandez and Bahadurin studies suggest you should begin seeing measurable reductions in liver enzymes if they were elevated. The 18% ALT reduction in the Hernandez study occurred at 6 weeks. If you are not seeing any movement in liver enzymes at this time frame, something is working against the protocol. Alcohol, ongoing high-processed food intake, a medication side effect on the liver, or an underlying condition that warrants medical evaluation before proceeding with self-directed protocols. At 3 months, the lipid and glucose changes that PREDIMED captured in its longitudinal data begin to manifest. HDL typically rises. LDL particle quality shifts. This is the part your standard lipid panel does not measure, but the ratio of total cholesterol to HDL and the triglyceride to HDL ratio begin to improve. These are actually better predictors of cardiovascular risk than total LDL, and they respond more meaningfully to the protocol here than to statin therapy alone. At 6 months and beyond, the cardiovascular and cognitive effects that the PREDIMED population experienced over nearly 5 years of follow-up are building. The PREDIMED effect on cognitive decline was measurable at this time frame. The effect on cardiovascular events required years because cardiovascular events are rare, but the underlying biomarker improvements that predict cardiovascular risk reduction begin earlier. If your liver enzymes are more than 3 times the upper limit of normal on repeated testing, or if you have any symptoms I am about to mention, this protocol is not where you start. You start with medical evaluation, yellowing of the eyes or skin, jaundice, severe pain in the upper right abdomen, dark urine that is not explained by hydration, unexplained significant weight loss, confusion or significant personality changes, swelling of the abdomen. These are signs of serious liver dysfunction that require immediate medical attention. This protocol is designed for people with subclinical or early-stage metabolic liver dysfunction, not for people with advanced liver disease. Let me bring this together. The system has been treating chronic disease, cardiovascular, metabolic, cognitive, as a collection of separate problems with separate pharmaceutical solutions. The evidence from Schulson in the Journal of Clinical Investigation to Estruch in the New England Journal of Medicine to Weinstein in Hepatology points consistently toward the liver as the metabolic center that connects these conditions. When liver function is compromised, the downstream consequences are systemic. When liver function is supported, the benefits are also systemic. The largest nutrition trial in medical history, 7,447 participants, nearly 5 years of follow-up, published in the most prestigious medical journal in the world, found that extra virgin olive oil at a therapeutic dose reduced cardiovascular events by 31% and new diabetes by 40%. A 6-week RCT showed that replacing saturated fat with extra virgin olive oil reduced hepatic fat by 15.3% and improved insulin resistance by 21%. A 4-week double-blind trial showed that sulforaphane-rich broccoli extract reduced liver inflammation markers by 23%. The mechanisms, hepatic inflammatory signaling, NRF2 pathway decline, and the liver-gut-brain axis, explain why these dietary interventions produce systemic effects that go far beyond what their simplicity might suggest. This is not alternative medicine, it is research that was published in the most rigorous peer-reviewed journals in medicine, and that the clinical practice guidelines have been slow to incorporate because the incentive structure of the healthcare system does not prioritize it. You have been going to appointments for years and getting 10 minutes and a prescription. The information I shared today should be in those appointments. The fact that you are here looking for it tells me something about your situation. You have more agency over what is happening in your body than the system has led you to believe. Leave a comment with what your doctor has told you about your liver function, or about the connection between liver health and the symptoms you have been experiencing. I read every comment. It is exactly this kind of feedback that shapes what I research and publish next. This is Dr. Harris. Until the next one.